Hi, this is Professor Brandy Stanley, and today we are talking about the topic of suicide and non-suicidal self-injury. Many individuals will have suicide thoughts or suicidal attempts at some point in their life, and it is important for us to learn as nurses how to screen and intervene when suicidal thoughts do occur. And so that is what we are going to focus on today. Now, as you can imagine, the effects of suicide are devastating to families and to communities where it occurs. And in healthcare facilities, it should be a never event. Interestingly, the year before an individual completes suicide, 83% were seen by a healthcare professional and 50% had a visit to their healthcare professional within the past month. And so then you might start to think, how can we address this problem? And one of the things that we're going to learn about is how everyone everywhere who is above the age of 8 years old should be screened for whether or not they have suicidal thoughts. So now let's talk about a few terms that you need to be familiar with in order to understand the rest of this lecture. First of all, the term commit suicide is something we have all heard, and it uses language that is consistent with the commission of a criminal act. And so we should avoid this term because we want our patients to feel free to talk to us about any suicidal ideation that they may have. Next is the term suicide, and suicide is an actual death that is caused by self-inflicted injurious behavior with the intent to die as a result of the behavior. Suicidal ideation could contain any or all of the following: thinking about death, the wish to be dead, considering methods to accomplish death, and formulating plans to carry the act out. A suicide attempt is a suicidal act. It is engaging in potentially self-injurious behavior with the intention of death, and the attempt doesn't actually have to result in death for it to be a suicidal attempt. It can be injury or no injury, or death or no death. So here's something to get you started with the epidemiology of suicide, and there is about a 2 times higher rate of suicides than there are of homicides, and it is the 10th leading cause of death in the United States in 2019, and the second leading cause of death for individuals who are aged 10 to 34. Now, in that age range, breaks it up into 3 separate age ranges: 10 to 14, 15 to 24, and 25 to 34, but for each of those age groups, it is the second leading cause of death. There is about 1 completed suicide for every 25 attempts, and in 2019, they know that about 3.5 million people planned to commit suicide, and there were 1.4 million suicide attempts. Now, this is not going to include individuals who did not disclose that they were planning suicide. Firearms are associated with about half of all suicide attempts, and suicide is logically going to be higher in veterans. I can't remember what the statistic is on that, but I think it's 1.5 times greater among the veteran population than other individuals. Substances are often involved in suicide. For example, alcohol is associated with about 33% of all suicides. And interestingly, women do attempt suicides 1.4 times more than men do, but more men die by suicide than women do. And so the rate of suicides for men is about 3.54 times more. And interestingly, white males do comprise the greatest number of individuals who commit suicide at about 70%. When we look at comorbidities that are associated with suicidality, we do find that 46% of those who complete suicides are diagnosed with a mental illness. Major depressive disorders, substance use, and psychosis are the most common. 50% of individuals who complete suicide are experiencing a major depressive episode at the time of their death. And interestingly, anxiety disorders, eating disorders, personality disorders, and trauma-related disorders have also been associated with an increased risk for suicide. Precursors to suicidality are loss of relationships, financial difficulty, and impulsivity. For individuals who have been diagnosed with schizophrenia, it is the leading cause of death, and 20% do at least attempt, and I think they said as much as 15% actually complete suicides. It is usually related to depressive or negative symptoms that are associated with schizophrenia, not to the hallucinations. Substance use disorder also predisposes someone to suicidality, and part of the reason for that is it does reduce inhibition. So I do want to encourage you to look at the risk factors that are found in your book, but I want to talk specifically about the warning factors. And so when we're looking for warning signs, it is important for nurses to be familiar with these so that we can teach them to individuals in the community who might want to spot people who might be suffering from suicidality. So this might be something that you might teach to a school nurse or to parents or even to individuals within the workplace. So some warning signs or warning factors that might indicate an immediate risk of suicide would be finding people around you who talk or write about death, dying, and suicide quite frequently. Feelings of hopelessness, helplessness, or worthlessness, and talking about those might be another thing. And remember that when it comes to major depressive disorder, these are often associated with major depressive disorder as well. If we see somebody who has a sudden increase in alcohol or drug misuse, that is a warning sign because, as you know, these have been associated with increased suicide rates. Expressions of having no reason for living and no sense of purpose in life, or saying things like it would be better if I wasn't here or I want out, can also be signs. And so this might be something that, especially for individuals who have contact with the elderly population, they might find that elderly individuals no longer feel like they're contributing anything of value, and they do have an increased risk for suicide. Withdrawal from friends, family, and community is another warning sign, especially one that parents of teenagers might be attuned to. Reckless and risky behavior, seemingly without thinking about it, can be a warning factor because, remember, many times impulsivity has been associated with suicide. Dramatic mood changes are one of the warning factors, and talking about feeling trapped or like being a burden to others. And here again, individuals who worked with an aging population may find this to be an expression of individuals who have suffered maybe a stroke or something, and now they feel like they're trapped or they're a burden, and they are increased at risk for suicide. One of the things that we need to do for our patients is we need to screen everyone everywhere who is above the age of 8 years old. And we may find different tools for different age populations, but it is important that when we select a tool to screen someone for suicide, that we use an evidence-based practice tool. And so remember, when we talked about evidence-based practice last year, we talked about something where someone had implemented an intervention and tested it to make sure it worked. And so basically, when someone develops a tool like this, they implement the tool, they might even conduct a focus group to make sure that the wording is appropriate culturally for the area, and then they use it on different individuals to screen and compare it to already validated tools to see how accurate it is. So this is one such tool that has been validated by evidence-based practice, and it is one of the most common that you will see in practice. Now, there are simpler methods, but this one actually gives you a severity rating of the suicidal ideation, because it's a big difference between someone who has vague suicidal thoughts and someone who has suicidal thoughts with a very specific plan. So this is the Columbia Suicide Severity Rating Scale, and it is the one that has been selected by St. Anthony Hospital to be able to screen patients throughout the hospital setting, in psychiatric settings, in the emergency department, in the clinics, and even on the medical surgical floor. So you'll notice that it begins with a very typical suicide ideation question, and it's the topic of wish to be dead. And so they say, have you ever wish that you were not alive anymore, or wish to fall asleep and not wake up? And have you wished you were dead, or wished you could go to sleep and not wake up? And they encourage you, when you use this scale, to use the verbiage exactly the way that it is written, because it has been validated using the term, have you wished you were dead, or wished you could go to sleep and not wake up? At that point, you will check yes or no, depending upon whether or not your individual answers that they wish that they were dead at some point in time. And it says if the answer to question number 1 and or 2 is yes, then you complete the intensity of ideation section below. So the second question is, have you actually had any thoughts of killing yourself? So at this point, if the answer to question 1 and 2 are both negative, then you go on to the suicide behavior section. So as you can see, it probably takes a little bit of training to learn how to use this tool, because it sends you different places when you actually have different answers. But for now, we're going to go straight through it just to read through what it sounds like. And I want you to know that we will practice using this in class. And if you are using this at your hospital facility, they will train you in how to use it. The third thing is, have you been thinking about how you might do this? And so this is the idea of, have they actually developed any sort of plan? And then it says, have you had these thoughts and had some intention of acting upon them? So not only have they developed a plan, but they actually want to carry it through. Then you have the fifth question, which is, have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out this plan? So here again, we go from thoughts to specific thoughts to planning to intention to intent to carry out. And then we look at the actual lethality of what they have chosen, or whether or not they've tried to commit suicide. Is there no physical damage, minor physical damage, moderate, severe? And is the method, likely to result in injury, likely to cause death, likely to result in death despite available medical care? So we look at the different levels of what their intent is. For example, if somebody says that they want to cut their wrist with a razor blade, we know that most of the time this is not a terribly lethal method. If they, on the other hand, say that they have a weapon at home that they intend to put to their head, pull the trigger and shoot themselves in the head, this is a very lethal method. So there's a big difference between how concerned we are between one and the other. Now, let's look at the rest of the scale. And this is an actual attempt. So this is looking at their history, because if someone has in the past tried to commit suicide, they are much more likely to try to commit it at this time. So it says, have you ever had a suicide attempt? Have you ever done anything to harm yourself? Have you done anything dangerous where you could have died? And so here again, in the electronic health record, your facility will pick one of these questions to be able to ask to determine whether or not they have had an actual attempt. And then there's the part about interrupted attempt. Has there been a time when you started to do something to end your life, but someone or something stopped you before you actually did anything? And then there's the aborted or self-interrupted attempt, which is, has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything? And then there's the preparatory acts or behavior. Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills, getting a gun, giving valuables away, or writing a suicide note? So that all has to do with whether or not somebody has completed it or tried an attempt before, whether or not they've been interrupted, and whether or not they're preparing to be able to end their life. The next is the intensity of ideation section, and this talks about the frequency. How many times have you had suicidal thoughts? The duration. When you have these thoughts, how long do they last? And this helps you to know whether somebody is thinking about them all the time, or it's one little fleeting thought here or there. And then there's controllability. Can you stop thinking about killing yourself or wanting to die if you wanted to? And then there are deterrents. Are there things or anyone or anything that stopped you from wanting to die or acting on thoughts of committing suicide? So at this point, you may see individuals who say, I've had thoughts of suicide. I thought about doing it this way, but I have children at home and I would never do that to them. This is a very big deterrent that will keep them from actually committing suicide. Then there's the reasons for ideation. What sorts of reasons do you have for thinking about wanting to die or killing yourself? Was it to end the pain or stop the way you were feeling? In other words, you couldn't go on living without this pain or with this pain, or how you were feeling, all of that type of thing. And so here again, all of these things start to assess how severe their suicidal thoughts are. And this is just one type of suicide scale. Some of them are much more simple, but the Columbia is one of the most thorough out there, which is why St. Anthony's has chosen to put this in their different facilities in different forms. We go into much greater lengths to assess this in a psychiatric setting than they do on the medical surgical floor, but some variation of the Columbia Suicide Severity Rating Scale is used in every setting.